All right, well, welcome everyone. Today we are doing our module 6 of our antimicrobial stewardship series with Dr. Westley, and without any further ado, I'm just going to hand it over to him.
Okay, great. Thanks everybody taking some time, and if you're listening delayed, thanks for listening delayed. This module is on the topics you see here on the slide. Accreditation statement disclosure. So here's what we're going to try to do today. We'll discuss some just basic initial management of complex infectious disease scenarios. These are fever, sepsis, neutropenia with fever, and then bone and joint infections and endocarditis. Really, there's a disclaimer, of course, these patients are very complex, and really all of them should be managed with infectious disease consultation wherever available at all. And the main purpose of the stewardship program is to identify these patients. Sometimes they don't have consultations and need it, and can help with that. And also just to make sure at least the empiric regimens are appropriate for what's going on, and maybe nudge the doctors if they need help. So there's a lot of different guidelines for these indications. I've tried to update them in the reference slide here. So let's just talk about sepsis briefly. When people are sick with an infection, septic, fever, tachycardia, high white blood cell count, perhaps low blood pressure if they're in shock or inadequate perfusion, if they have severe sepsis, that's a medical emergency. So they need immediate evaluation and management. All these patients should get blood cultures and an X-ray and urine, basically, at a minimum, particularly if there's no obvious source for what's going on. So this should be directed by symptoms. If somebody's got painful urination and a flank pain, you're thinking they have pyelo. If they have coughing up sputum, shortness of breath, chest pain, you're obviously thinking they have pneumonia. This is not to say that somebody that's septic with pneumonia needs a urine sample. This can be targeted. All patients that are septic should get blood cultures, though. If you don't know this, if you know what the source is, then we are already ahead of the game, because we've talked about what the appropriate antibiotic regimens are for various infections, depending on the severity, for example, with pneumonia or with urinary tract infection, et cetera. So if you know what's going on, you treat that. But if you don't know what's going on, then we need to assume anything could be going on. There could be bacteria in the blood, and we don't know where it's from yet. There could be something going on in the abdomen. Sometimes the abdomen exam is underwhelming, and there's a big problem in the abdomen. So if we don't know what's going on, we typically give treatment for bloodstream infection plus pneumonia, plus intra-abdominal infection, plus skin and soft tissue infection, plus urine infection. So we cover everything with a regimen such as vancomycin and piperacillin and tazobactam. You could use cefepime and metronidazole instead of the pip/tazo, and we need to search for a source. Definitely at least an X-ray of the chest and a CT scan of the abdomen. I still on occasion get called for really severely septic patients. Nobody knows what's going on and they haven't been imaged, and it's important to image them. Some programs do use a procalcitonin to try to decide how long to treat patients with sepsis, but the procalcitonin level should not be used to decide whether you're going to give antibiotics to a septic patient or not. They all need antibiotics up front until we sort out what's going on. If you don't find any source, nothing happens, and the patient gets better in 24 or 48 hours, that does happen. Sometimes people that inject drugs inject particulate matter that's very inflammatory. They can get a SIRS syndrome without infection. Some people look septic and nothing's ever found. They get better quickly. And in that case, there is some literature that if the procalcitonin level drops over 80% from baseline or is very low, that the antibiotics can be stopped after a couple of days. Frankly, they may be able to be stopped even without checking a procalcitonin level if the patient's better after a few days, but that's going to be a minority of cases. So we talked about this trial before, and that's the question of whether to use cefepime or pip/tazo. So I just thought I would bring it up again, because this trial was literally a trial of septic patients that were given vancomycin plus either cefepime or pip/tazo as empiric gram-negative coverage in septic patients where they didn't know what was going on yet. And it really showed that there was no difference in acute kidney injury using the combination of pip/tazo versus cefepime, but there was more delirium and coma in the cefepime group. So either of those regimens is probably reasonable. There may be a slight swing back to pip/tazo as the backbone in those patients. It's a little cleaner too, because if you're treating intra-abdominal infection, you just need one drug instead of two. So this would be vancomycin versus vancomycin and Flagyl in most of these severely septic patients. Then the next thing I thought I would just mention about the sepsis patients is frequently we see this where patients are bacteremic. So they have bacteria in the blood. Maybe they have group A streptococcus or gram-negative in the blood by the next day, and we know what's going on. And a lot of times they get repeated blood cultures, sometimes over and over again for days. And so, and part of this is partially led, in addition to supply shortages of last year, there was a massive shortage of blood culture bottles for the for some of the machines, one of the systems that does blood cultures. So there was a big shortage around the country. And it really turns out that we're not being evidence-based about how we check and how we repeat blood cultures. So this study that was done by Valeria Fabre at Hopkins, she actually was a resident when I was a fellow at Brown. And what they basically showed is that only 2% of blood cultures in patients with fevers grow anything in these big series. And 30 to 50% of the blood cultures that do grow something turn out to be contaminant, which is a massive chunk of the positive results are worthless. And if anything, they can mislead you and lead to inappropriate management. There has been shortages of blood culture bottles in media in recent past. And probably about, they estimate 40% of blood cultures are inappropriately ordered and aren't necessary. So yeah, this is disappointing. I don't know why. Is this real blurry for everybody?
Yeah.
That's odd because it wasn't blurry on my initial study. I wonder if I'm operating off of a not fully downloaded version. Let me just try to get out of this real quick because that's hard to read. So let me just stop sharing for a second. Let me see if I can pull up a better version of this. So something weird's going on. Give me a second. Oops.
I'll check my version and see how it looks.
Yeah, I think I pulled it up from my email, and it might just be that I didn't fully download it to the desktop and then.
No, the one you sent me is also blurry.
Oh, shoot. Yeah. Okay, well, we're just going to have to muddle through, and I'll just have to.
We'll send a copy of the clean slides to everyone.
Yeah, there's somehow when it came through the email, it's definitely on my laptop. It wasn't like that. Yeah, and it might be. Yeah, I don't know what happened. Okay, so let me share again. Let me get back to the Zoom. Share screen. Yeah, it's a bummer. So, but we'll just muddle through. So basically, what this algorithm is basically gonna show is when to order blood cultures. Is it a new event on the left or a recurrent event on the right? And then they give examples for when to get blood cultures or not, and they recommend them in various instances, but they don't recommend blood cultures for non-severe cellulitis, isolated fever with white blood cell count, cystitis, non-severe pneumonia, and this is kind of consistent with the guidelines we've already looked at. But then on the right side, possibly even more important is when should we do repeat blood cultures? And that is basically if there's Staph aureus in the blood, if there's an endovascular infection like endocarditis or a catheter infection and we're trying to salvage the catheter. But most of the time, follow-up blood cultures are not necessary. And we're probably overdoing blood cultures in the hospital. If somebody gets an isolated fever in the hospital, for example, the day after surgery, they get an isolated fever, a lot of time blood cultures are being obtained, and that's not very useful, and it's potentially wasteful and misleading. So they actually rolled out this that algorithm. They taught it. They had the posters up around their units at Johns Hopkins, and they showed a substantial reduction in blood culture utilization as they rolled this program out. In the medical units, the surgical units were the controls in this study. And so the surgical unit use of blood cultures did not change. but in the medical units, they had a substantial, like a statistically significant reduction in blood culture use. All right, so let's talk about bacteremias that are not Staph aureus. I briefly touched on this in another module, but this is an important one to have here. And if people come to isolated modules for information, it may be important to have the information in multiple places. So again, we have extensive data that shorter regimens are adequate for the vast majority of bacteremia, primarily two different things: multi-center randomized trial of 3,600 patients, which was the BALANCE trial in 2014, New England Journal of Medicine. So these studies were sick. Many of these patients were ICU level sick, but they had non-Staph aureus gram-positive, such as like pneumococcus or beta hemolytic strep, and they had gram-negative, such as you see with pyelonephritis or biliary tract infections. And 7 versus 14 days resulted in similar clinical outcomes. The other big study that we've talked about briefly was from the VA of 4,000 patients, and this was whether oral or IV beta-lactams can be used for gram-negative bacteremias from urine source, and they can. They saw no difference in relapse or mortality using oral versus IV beta-lactams, and they typically treated 7 days. They were short courses, 7 to 10 days. So that's really becoming the standard for non-Staph aureus bacteremia. This is the BALANCE trial, which we just talked about. The reference will be on the last slide. Multi-center, multiple countries, 7 countries, 74 hospitals, sick patients, no Staph aureus, and they showed a substantial non-inferiority of 7 days of treatment. And then this is the study from the VA on oral beta-lactams versus quinolones or Bactrim. So this is a question: can you use cephalexin, for example, for a susceptible E. coli when it's a urine source and in the blood? And they saw no difference. We should, however, talk briefly about Staph aureus specifically, because that is excluded from those short course studies. There is an accepted dogma currently that 14 days of therapy is the minimum that's adequate for these infections. And if you give less than 14 days, the relapse rate is higher. I don't show that study here, but it's pretty well documented. But the question has long time been, does every patient need an intravenous drug the whole time or not? And it seems like it should not be, intuitively, what we know about antibiotics getting into the bloodstream. But this was an international open label randomized trial to look at that called Sabato. Big news about 2 years ago. And what they did was they gave 5 to 7 days of IV therapy, and then they gave orals if the follow-up blood cultures were negative. These were done at 24 to 96 hours. You could not have positive follow-up cultures after antibiotic start, 24 to 96 hours. There were some pacemaker patients and dialysis patients here. You could have a prosthetic joint as long as the joint wasn't infected. And many of these patients had either central lines or they had drained skin abscesses. They excluded complicated bacteremia, which basically means the bacteria went from the blood to another source, like an ankle or something. They excluded people that didn't have devices removed, like a line infection that you're trying to salvage the IV line, or if they had a known infected pacemaker or an infected endovascular device. And they excluded people with drug use, prosthetic heart valves, and immune compromise, like transplant patients. There were 213 patients. They wanted a bigger study and they had trouble with enrollment, unfortunately, but there are still some important outcomes. And they treated these patients for 14 days. A little over half got cotrimoxazole, which is trimethoprim sulfamethoxazole. They call it cotrimoxazole because it was a European study, so I left the terminology. A third got clindamycin and 8% got linezolid. Linezolid is what most experts in the United States probably would use. Maybe some would use cotrimoxazole. We get nervous about sulfa drugs because historically there has been felt to be, compared to intravenous cefazolin, suboptimal therapy with sulfa drugs in Staph aureus bacteremia, but many of those patients probably had complicated disease. And this study saw no difference in relapse of infection, development of deep-seated infection after starting treatment, or in mortality. So it seems that in carefully selected patients with an immediately source controllable infection, like a drained skin abscess or a central line that's removed, if they meet the criteria seen in this study, a swap to oral therapy for 14 days is probably reasonable. And I get to do this a couple times a year now. These patients are few and far between because many patients have complicated disease, and it's why they had so much trouble with enrollment. They screened thousands and thousands of patients and had trouble enrolling. But if the patients meet the correct criteria, this could be considered. It should be done in conjunction really with an infectious disease specialist, not by non-specialists. Okay, let's move on to fever and neutropenia. So this basically is defined as neutrophils less than 500, or if they're less than 1,000, but we know they're going to go under 500, and then there's fever, 101 or over 100.4 for an hour. And the patients need blood cultures, and then they need an examination. Any other testing like x-rays, urines, and everything, basically should be symptom directed. The typical approach is to give a drug like cefepime that covers Pseudomonas and gram-negative rods, as well as streptococcal species, including alpha strep, viridam strep species. 2 grams every 8 hours alone. Ceftazidime is not preferred because ceftazidime does not treat all viridam streptococcal species, which come up a lot, especially in patients with mucositis. If we know what's going on, like somebody's got pneumonia, skin and soft tissue, and abdomen, then we want to use a broad range regimen for that. So like for the abdomen, we would want to use piptazo, or if somebody has pneumonia, we would want to use a drug that covers Pseudomonas. If we don't know what's wrong and the patient's unstable, we typically add vancomycin, probably mostly because the vast majority of these patients do have central lines in place. And you know, a lot of them will end up having a line infection. If they're very, very sick, you also need to consider whether we need a second gram-negative drug. And these patients, we like it if infectious disease is called early, at least in our hospital. I want them to call us for these. After a few days, if the patient is sort of, you know, stable but continues to have high fevers, then it becomes more complex. Fungal infections do occur. And so an antifungal frequently would be added by the guidelines, but then we would ask them to contact us. A lot of times we're going to want to do a chest CT or some other imaging and try to figure out what's going on. So patients that have neutropenia and shock neutropenia and they're bacteremic or fungemic, if they have an intra-abdominal infection or they have spots in their lungs, we want to be involved with these patients. And again, if their fever does not go away after several days, we want to be involved. Trying sometimes to figure out exactly what to do with the antibiotics once there's an infection and how long to give it, and then if more antibiotics are needed in the future for ongoing chemotherapy or something, these are really hard cases even for us, and so we'd like to be involved with those too. So this next question is, how long do we treat these, basically? And the nice thing about trying to remember the name of some of these studies is, I can't remember how long to treat neutropenic fever, and the name of the study is How Long. It's the How Long study. And this is actually a study in Spain, randomized. It was open, but they were hematologic malignancy. So basically like leukemia patients, sick patients. 157 patients were randomized. And what they basically did was, if the patient was 72 hours without fever after starting antibiotics, they stopped the antibiotics even if the neutrophils were less than 500. That was the experimental arm, or they continued until the neutrophils were also over 500. That has kind of been the historical standard. The antibiotics continue until the neutrophils are over 500. But that can be a big, big problem in patients with these forms of leukemia, because sometimes they're neutropenic for months. And it's hard to get people off of antibiotics. There was less antibiotic use in the early stop group, which makes complete sense, of course, but there was no increase in fever or infection relapse in the early stop group. So that was good. So the summary and the conclusion from these authors was that in patients without a fever who are clinically improved, that you can stop antibiotics safely after 72 hours without fever, even if the neutrophils remain under 500. And these are patients where there was not an obvious source of infection found. Because, for example, if you had pyelonephritis, of course, you'd want to treat for 7 days. These are in patients that have a fever, nothing pans out, and blood cultures are negative, and then the fever goes away, then you can stop. So the next thing is fevers in the hospital. This happens all the time. Sometimes we get called about these. Sometimes we just know about them from our stewardship programs. And there's very, very reasons. Very, very many reasons this can happen. There can be a nosocomial infection, like even a peripheral line, an IV catheter, central line catheter, urinary tract infection, pneumonia. There can be a drug fever, blood clots, and pulmonary atelectasis could cause fever. Patients with brain injuries after trauma can have central fevers. Patient could get sinusitis or some other problem, especially if they had endotracheal tubes or nasal tubes in for a long time. Pseudogout and gout flare in the hospital frequently, especially if there's renal dysfunction. I should just have postoperative, isolated postoperative fever on here, which isn't really the same thing, but if there's fever within 36 to 48 hours postoperatively that's low grade, transient, the patient's stable, nothing really needs to be done about that. So the most important thing, in my opinion, is really like that the patient needs to be seen and evaluated by a doctor, and they need to ask them, hey, how are you feeling? What's going on? Take a history and then examine the patient. Because otherwise you just don't know what's going on. Fever in and of itself is not much to go on. So we need to examine the patient. If there's clearly fever and no other source, then we need to consider whether we should do blood cultures. I just showed you that the newer pathways actually suggest that in the absence of sepsis and in the absence of any sort of localizing findings, and in the absence of a central IV line, for example, blood cultures are probably not very helpful. But patients can get peripheral IV line infections. We do see that multiple times a year. Usually they will have some even mild phlebitis or tenderness developing at a peripheral line. So the exam is important to look at that. The doctors need to do that. And then if there's shortness of breath, cough, etc., or if there's urinary symptoms, further samples can be obtained. Not everybody with a fever who feels fine needs what we used to call pan cultures, where we get a culture of every body fluid we can obtain. And that's a little excessive without any directed exam or directed history. Most fevers in the hospital don't need new antibiotics or don't need the current antibiotics to change, because many of them are not infectious. So work up as directed by your history and exam, and then wait for the results if the patient's stable. If the patient's septic and the heart rate is 120, 130, the blood pressure is soft, the patient's looking ill, then of course, if the patient meets a sepsis criteria trigger, which the EMRs typically trigger us as well as a full review, then yes, patient does need antibiotics. But most people with fever in the hospital are not actually septic at that point. Now if a central line infection is suspected, what do we do? If the only way to really know a line's infected is that the cultures will grow once the cultures are obtained, and that takes some time. The general recommendation is we shouldn't be pulling lines out of every patient with a fever. The time to consider it is if a patient's really ill. If somebody's moving to the ICU because they're unstable and there is concern that they could die overnight or die in the next 24 hours, then removing the lines empirically is reasonable if there's a high suspicion for that. But as a general principle, in some facilities, I have seen a pathway where almost just a priori, if a patient with a central line develops a new fever, the central lines are changed, and that should not be necessary. How about in the ICU? So this happens to me quite a bit, and it will happen the rest of my career. I'm absolutely guaranteed. But I enter the room and find yet again a patient has fever and they're getting Tylenol or ibuprofen scheduled or PRN antipyretics, and they're covered in one of these cooling blankets with like cold water or whatever circulating, and the patient looks uncomfortable and cold and feels cold. And I'm thinking to myself, man, if I had a temperature of 102 and felt miserable, and then everybody just puts ice all over me and it doesn't make me feel better, I'm not sure that that's helpful or that I would want that. So it kind of drives me crazy that in the intensive care unit where all sorts of crazy stuff's going on, that a temperature of 101 or 102 is a nursing emergency. And part of the reason it drives me crazy is because there's clear guidance on this. This is from the Managing Sepsis, Surviving Sepsis and Managing Sepsis Pathways from the intensive care doctors. And there's data, and it specifically says in one section, recommendation number 2 is for critically ill patients with fever, we suggest avoiding routine use of antipyretic medications for the specific purpose of reducing the temperature. There is moderate quality of evidence, although it's a weak recommendation. They don't address cooling blankets or ice packs on the forehead or anything like that. But the evidence is that even patients that are hypotensive or are septic, that aggressive control of temperature it does not improve outcomes. So the data is clear that controlling temperature does not appear to improve outcomes in the ICU. So getting really aggressive about trying to keep temperature under 100.5 doesn't appear to benefit the patient. There's no benefit to 28-day mortality, hospital mortality, or reversal of shock with aggressive temperature management in the ICU. Okay, so let's talk about line infections again, because in the ICU we do see these on occasion. As a sort of conceptual outline, I think of we talk about 3 different types of line infections. There can be infection inside that lumen of the line, where bacteria are inoculated by accident. As we attach and give medication through the line, bacteria gets inside the lumen, the hollow part of the line, and grows in there. On occasion, certainly happens not too infrequently, if there's organisms in the blood that come from another source. Let's say, for example, a patient has an intra-abdominal infection and translocates yeast into the blood from ischemic intestines, that can stick onto the line, or Staph aureus can stick onto the line, and then you have an infection. You can conceptualize it on the outer part of the lumen in the bloodstream that got stuck on there from a hematogenous source from somewhere else. Or you can have an infection in the tunnel or in the pocket around a port, so it can get red, tender, and indurated soft tissues around the skin component. How do we diagnose these? And this remains controversial if you talk to doctors or you talk to the agencies that have to report infections to the National Healthcare Safety Network. Part of it's probably because hospitals don't like to have bad numbers of what kind of infections they're having in the hospital. And the reporting states that blood from peripheral blood draws is completely fine, and if there's blood that grows peripherally, that defines a line infection. The guidelines for line infection diagnosis and treatment from the IDSA are old, from 2009. They recommended culturing each line and peripherally when line infection is suspected. It increases your yield. There are occasions where the line is clearly infected and will grow Staph aureus or yeast, and the peripheral blood does not, and that's still a problem. But when you draw from the line, there is a higher chance that you'll pick up some type of contamination from the hub as you draw the blood. So if you get a non-pathogen commensal flora, that may not indicate a line infection, and it used to lead to some problems because those organisms weren't fully excluded. Now they're excluded, so there really shouldn't be an increase in reporting from central line draws, but most hospitals get really uptight about this issue, frankly. When we do draw cultures, just standard blood cultures are fine. Quantitative or fungal cultures are not needed. And then if something grows in the blood and there's no reason for it to be in the blood, that's a line infection. If there is Staph aureus in the blood for no other reason, no skin source, no foot infection, no primary pneumonia, for example, then that's a line infection for sure. However, commensals, so like I say, if you have, and that's just a single blood culture. So if you have a single blood culture with Staph aureus or yeast, that's a line infection. If you just grow a normal skin bacteria, things, for example, C. acnes or coagulase negative staphylococcus, skin commensals that are everywhere, if they only grow in one culture, does not define a line infection. They need to be the same exact organism in multiple cultures to prove it's real. And then it would meet reporting criteria, which makes sense. If you just draw a contaminant type organism from the line, nothing grows peripherally, that's not a line infection for reporting criteria or clinically. It's got to be in multiple cultures. The line's infected, it really should be removed. There are very rare instances when we don't do that, when people come from outpatient with chronic lines. But this is especially true if it's Staph aureus, Candida, or gram negatives, if the line is the problem. Those are very hard to cure. Once the line's removed, the duration of treatment differs depending on the organism we're treating. Coagulase negative staphylococcus may not even require systemic therapy. The guidelines tacitly allow for potentially no systemic therapy or very short durations. 5 to 7 days are probably the most commonly used. Enterococcus and gram negatives, typically 7 days are given from line removal. Staph aureus, we just talked about, 14 days. These occasionally are patients that can be converted to oral therapy. I'm saying that because one of my real pet peeves has been for many years that a patient gets a central line placed to give treatment for Staph aureus that they only have because they previously had a central line that was infected and got removed. So putting a central line in to treat a central line infection is counterintuitive to me, and I try really hard to avoid that. And then Candida species, which are yeast, these can be quite complicated and problematic, so they need at least 2 weeks of therapy from the first negative culture. The drug you use, the dose, and any other workup, it depends on multiple factors, and somebody with infectious disease should be involved if at all possible to help with that. Sometimes we do have to try to salvage lines, especially in children or usually younger adults with a short intestinal tract and they need TPN long term. But there are a few other instances where we really feel forced to try to salvage an IV line in place and cure it. And the guidelines and best evidence suggest that several weeks, 2 weeks of antibiotics, but also with locking the line with antibiotics is the best approach. We try really hard not to do this with bacteria that can kill you if they don't come under control. So wimpy bacteria like P. acnes or coagulase negative staphylococcus are ones that we would think about maybe doing this if we have to. We try really hard not to do this for Staph aureus or yeast because it just does not work well, especially with yeast. And then if there's a tunneled line or a port and there's cellulitis and induration and redness along the tunnel, or there's cellulitis and induration over the pocket of the port, oftentimes there's pus in there as well. They just really cannot be salvaged, and the guidance is clear that they should be removed in the guidelines for line infections. All right, so we'll briefly move on to bone or joint infections. So there's a couple different routes for these, especially in children. These are typically bacteria that get into the bone or joint through the bloodstream. So a hematogenous route. Staph aureus and beta hemolytic strep are most common, but you can see gonococcus, you could see pneumococcus, occasionally gram negatives and other things. You can also have an inoculation or a contiguous type infection. So for example, the most common might be after surgery, or somebody gets a arthroscopy or gets a knee surgery, ACL repair, and then it gets infected. And these are sometimes multiple bacteria, although they can be a single bacteria like Staph aureus. And then there's another category of prosthetic joints. You get a knee or hip replacement, or a shoulder replacement. And then the metal is infected. Those are complex and problematic. So in kids, we typically try very, very hard if the child's not severely septic. So if there's fever, but the hemodynamics are stable, we want to get aspirated fluid from the joint and blood cultures before starting antibiotics. And then we would start something that covers Staph aureus, strep, and in young kids, Haemophilus influenza can be a problem. So usually vancomycin and ceftriaxone in children. In adults, it can be the same regimen, but the ceftriaxone is primarily to treat gonococcal disease. In Alaska, we have a massive increase in disseminated gonococcal disease over the last 1.5 to 2 years, and our rates are 10 to 20 times what they should be for the amount of gonorrhea we have right now. There was just an epi bulletin a few days ago about it. So that's where the ceftriaxone comes in. And then we need to get cultures. We always need to know what organism is in the joint and or bone, if at all possible, so we can properly treat them. So for these surgical ones, gram positive and probably something gram negative is frequently given up front. These are really individualized cases that should be treated with infectious disease help. And the same can be said for prosthetic joints. We always want to get fluid out of the joint before starting antibiotics. We always give a drug that covers Staph aureus, including MRSA. And then many experts give gram negative coverage empirically as well, especially if they're unstable or you see a gram negative. If it's a subacute onset, we may not give gram negative coverage right away. So in kids, actually, we treat these for 3 weeks, 6 weeks of bone infection, though there's a move to treating bone infections for 3 to 4 weeks. We also know that oral therapy is just as effective as IV therapy in children, and we've known that for a couple decades. We now are using a lot more oral therapy for bone and joint infections in adults, which I'll mention in a minute. Prosthetic joints typically need to be removed, though sometimes we debride and retain the implant, debridement and implant retention, if the infection's been only present for 3 to 4 weeks. And those are complex regimens that need to be treated with our help. For Staph aureus, we typically give rifampin plus something else for 3 months. We give 6 weeks of antibiotics if the entire implant has been removed as a standard treatment. So the question in adults for a long time has been, should medicines for bone and joint infections be given intravenous or orally? And we have some pretty decent evidence on this that is finally perfusing its way through our specialty. This is New England Journal 2019 called the OVIVA trial, oral versus IV. 1,000 patients in 26 centers in the United Kingdom. And what they did was within 7 days of surgery, or within 7 days of starting antibiotics, if patients didn't have surgery, they randomized to IV or oral treatment. So these patients got less than or equal to 7 days within 7 days before switching to orals versus standard care where they got IVs. And these included prosthetic joints. It included hardware infections on bones that were broken, and then the hardware to repair the fracture became infected. It included vertebral osteomyelitis and included epidural abscesses. They excluded Staph aureus bacteremia and endocarditis appropriately, because that's a different deal. And then they found treatment failure in 14.6% of the IV group and 13.2% of the PO group. So lower in the PO, and it was obviously not statistically significant. But of course, there were many more IV catheter infections in the IV group, because it's quite hard to have an IV catheter problem if you don't have an IV catheter in place at all. So 9.4% of the IV therapy group had some type of catheter complication during their treatment, and only 1% of the PO group had a catheter complication. So this is very reassuring, and these are many of the cases that we see now that historically we had treated with intravenous therapy for long periods of time. And I've probably eliminated 90% of my use of outpatient IV antibiotics over the last few years based on this new data. So it's pretty exciting. I guess I should mention that in these cases, the prosthetic joint was appropriately removed or managed surgically. And then the same thing for orthopedic hardware infections, that the hardware was appropriately debrided. Ideally, the source control was removed, or if the hardware was left in place, at least it was operated on in the vast majority of cases. And the last thing I'll say about that study actually is that about 15% or so of the oral group didn't get any IV antibiotics. They were started immediately on oral antibiotics. So IV antibiotics are not a mandatory component of that study. Okay, so in children, most of these are hematogenious, and there's great data that oral therapy works just fine for children. We switch to orals as soon as they're clinically improving and the CRP in the blood improves. 3 weeks for joint, 6 weeks for bone, but 3 to 4 weeks for bone is probably actually okay. That's the new data. And then IV therapy and PICC lines are almost never necessary for bone and joints in children. And again, in adults, we're moving away from it, though a lot of specialists still do it. I've really moved away from PICC lines and IV antibiotics for bone and joint infections in adults as well. Native vertebral osteomyelitis, I want to talk about briefly because this comes into emergency departments all over the state, and although most of it ends up in Anchorage, the upfront therapy can really be helpful, or the lack of therapy. So native basically means there's no hardware or prior surgery. So just spontaneously vertebral osteomyelitis develops. It's usually one bacteria that gets in there from the bloodstream, Staph aureus, beta strep. There could be weird things like brucella or TB. There also could be very unusual organisms, yeast or lactobacillus in people that inject drugs. If the patient is stable, and many of these are chronic with pain for weeks, some have fever, but many don't. If the patients are not septic and they don't have paralysis or some severe neurological impairment from infection, the Infectious Disease Society of America guidelines for diagnosing this and treating this recommend not giving antibiotics until tissues obtained, because we need to know what the organism is. If we don't know what we're treating, we won't get it right. If the patient has tuberculosis and we give them vancomycin, that's not going to work. So our radiologist, the interventional radiologist, IR, we ask them to aspirate from the disc, or if there's bone they can obtain with a bone needle before we start antibiotics, and we send it for bacterial. And then here we have more TB per capita than anywhere. We oftentimes also send this for mycobacterial and fungal cultures and PCR studies. We have repeatedly found that PCR testing on the tissue is a much higher yield than culture-based diagnostics. This is not formally advised in the guidelines that were written almost 10 years ago now, but I think the literature is expanding on this, and our experience is definitely expanding on this. So this is my personal recommendation. If the initial samples don't show anything, we try very hard not to just start antibiotics immediately after the aspiration, because a lot of times only a tiny little bit of tissue is obtained. And so I prefer to not give antibiotics and repeat the biopsy for a larger chunk of tissue, sometimes with surgery, or at least a repeat needle. So I withhold until we have a diagnosis. Some of these are not infectious, and we give them antibiotics and they're not. If the blood grows something that frequently causes spine infections, then we can assume that's the problem. Staph aureus particularly, the guidelines endorse that if there's Staph aureus in the blood and you have vertebral osteomyelitis, you can make the assumption that that's the problem. You do not need to stick a needle into the disc or bone. And those blood cultures usually turn positive pretty quickly. Everybody with this needs blood cultures. So all patients with vertebral osteomyelitis need blood cultures before getting antibiotics. This may hold true for other things in the blood, but not necessarily everything, especially if you pick up coagulase negative staph or something like that. There could be a lot of diagnostic confusion. So we really recommend talking to us about these patients. But the main thing is, it makes it hard to diagnose these patients if they're just put on antibiotics for days before they come to a facility where we can do the diagnostics. And then how we treat it varies by organism. The standard is to give 6 weeks of therapy. That's in the guidelines. We now know from the data I just presented that oral therapy and IV therapy appear to be equivalent based on the OVIVA study that included these patients. I like to follow the labs every few weeks just to make sure the antibiotics seem to be working. Partly because the pain that people have when their spine's infected really lingers and improves slowly. The labs get better before the pain sometimes gets better. And there is mention in the guidelines that repeat MRI imaging is not indicated for somebody improving because those MRI scans will remain abnormal for many months, sometimes 6 to 12 months after successful treatment. And the MRI can mislead us into over-treating patients. And again, we want to be involved with these. Okay, so the next topic I just want to briefly talk about is hardware infections. From orthopedic hardware, where you have a fracture, hardware gets put in and it's infected. It can get infected very quickly or sometimes months later. The hardware is a nidus of infection. Sometimes I tell people it's like having a splinter in your hand that's infected. If you give antibiotics, it may look pretty good for a while, but then when you stop the antibiotics, it's going to start draining and become a problem until you remove the splinter. Although I admit splinters are easier to get out than orthopedic hardware. So preferably the hardware comes out when an infection is diagnosed. But if a fracture is not healed, you cannot take the hardware out without the bone falling apart. So occasionally the hardware needs to stay in place while the infection is treated and suppressed until later the hardware can be removed. A lot of experts add rifampin when there are staphylococcal infections and hardware in place. It's a little harder to know if this is required compared to orthopedic prosthetic joint infections where we know for sure that rifampin is associated with cure. In this case, we don't know for sure. The hardware is going to come out anyway. The rifampin may not be incrementally beneficial, but some of us will do that. And again, this should be an infectious disease consultation. I think our last major section is endocarditis. This is diagnosed with an algorithm at Duke that was created many years ago and has been modified in more recent years. And basically, to know for sure somebody's endocarditis, you need to know that either there's bacteria in the blood or there's an obvious growth on the heart valve, plus you need to have something else. Valve condition, fever, embolic lesions, these are the formal criteria for diagnosing endocarditis. 2 majors or 1 major and 3 minor criteria, or all 5 minor criteria would confirm the diagnosis. Most important is to get the blood cultures first. Guidelines recommend 3 rather than 2 sets if we have high suspicion. And then the heart needs to be imaged, and a transthoracic echocardiogram on the surface will pick up some cases, but they will miss up to half of cases of endocarditis. And so a TEE, a transesophageal echocardiogram, is really the gold standard for imaging these. Once the blood cultures are obtained and there's high suspicion, then antibiotics with vancomycin and ceftriaxone are typically what's given. So this covers all the usual organisms we worry about. Once we make a diagnosis, treatment is complex and varied depending on multiple issues: what type of valve, what organism, the patient themselves, what's going on. We don't use gentamicin any longer, and surgical decisions are very complex and somewhat controversial. So these really, all infectious disease, all endocarditis cases should be managed with our input. This is a brief mention of something that has not fully perfused its way through our specialty yet, and I'm not yet comfortable with this, but there is a study from 2019 was in the same journal, same New England journal that had the OVIVA study, and this was a POET study of left-sided endocarditis therapy of 400 adults, mostly in Europe, actually all in Europe, I think. A quarter were prosthetic valve disease, and they did 10 days IV minimum, then oral, or they randomized them to IV or oral. They used regimens that are not frequently used in our country. A lot of patients got fusidic acid, some got linezolid plus other drugs, and some got beta-lactams and rifampin. That was the most commonly used combination. But the combinations were not fully mandated by the study, so they were clinician picked, and it makes the generalizable data just a little harder to be comfortable with. They did, however, find that oral therapy was not inferior to IV therapy. This may be an option then for carefully selected patients. It's not the standard of care in our country. Many of the regimens used there were not available. And so this is something that when we struggle with IV therapy and feel like there are not many options other than to use oral therapy, we've been using this study to help guide us, but this has not become standard of care, and I think it's got a ways to go. And then lastly, we need to talk about these pacemaker infections. These cardiac devices, they will come to Anchorage. There's really one facility that can remove these. But some general information is important for stewardship pharmacists. So by far, staphylococcal species are the most common. This can happen with a pocket, oftentimes shortly after implantation, that develops pus, cellulitis, and drains or is tender, and the patient may or may not have fever. Sometimes the device will erode just right through the skin, and there's not much infection at all, just an erosion, and the device is coming out. Or you can have bacteria in the blood that gets stuck on the wires. We always need blood cultures in these cases before antibiotics. If there's bacteria in the blood, the patients always need a TEE to decide whether they have endocarditis or not. In very, very limited early superficial skin erythema or infection, a short course of antibiotics occasionally can prevent a deeper pocket infection, and that is what the guidelines state to do. The only ones I ever see are the ones that failed that are in the hospital and are coming out. So you can have a very limited incisional infection early, but otherwise, in the vast majority of cases, the pocket will need to be debrided and the entire device, including all the wires, has to be removed. Sometimes that's easy, sometimes that's hard, depending on how many wires, depending on whether the patient's heart will actually beat without the pacemaker in place, and depending on how long the wires have been in there. Sometimes they're very hard to get out if they've been in there a long time. So these people need cardiology, electrophysiology specialists, cardiac surgeons, and infectious disease specialists to manage them. So complex. And I think with that, I will stop. I'm going to exit this. I'm going to stop sharing so I can see people. And we've got just a few minutes left for questions if anybody has.
There was one in the chat from earlier on.
If it's such a high percentage of blood cultures are contaminated, why do them at all? Well, if you don't ever do blood cultures, you don't know somebody's bacteremic, so you couldn't make half of these diagnoses, unfortunately. But we should not be doing blood cultures when people should not be getting blood cultures. So that's where the evidence is evolving, is that isolated fever in the hospital, for example, patients with cystitis, patients with non-severe soft tissue infections or diabetic foot infections should not get blood cultures, because 30 to 50% of positive results are contaminant. But we should be doing blood cultures in people that are septic or we think have endocarditis or have a line infection, et cetera. The regimens in the OVIVA trial, I'm surprised I didn't mention that. Let me just go back to my own slides here and look if I mentioned what they used. Yeah, when I looked at this trial, I know that let me get back to my other page here. I don't have those regimens memorized. They used many different regimens, and it's in the supplemental data of the study. And I can include the study and the supplemental with the updated slides that aren't unreadable. So linazolid's in there. Highly bioavailable beta lactams, I think we're in there. My usual approach is to, for staphylococcal infections, I'm using linazolid primarily now for these. But highly bioavailable beta lactams like amoxicillin and cephalexin are also pretty good options. But I'll send the study and the supplemental. Other questions? I don't remember when our next, hopefully I've got a few weeks, because the next, I have to make a whole new.
April 16th on C. diff.
Yeah, that's a new one. I'm going to have to make a whole new one for that. Okay. All right. Yes, I'll get you guys the updated slides. Probably I'll send it tonight once I get home and make sure my images look okay. Okay. Thanks, everybody.
Thank you.